See, that is actually a very good point, because I remember the 966 study, the infamous 966 study, FOLFOX, XELOX plus minus bevacizumab was a multinational study, and we actually have seen data that there was a big difference in outcome by country. Mainly and if you had been randomized to go to country A versus country B, and I cannot name the countries here, you would have been, with the same protocol, drugs provided, all in English, would have had a 7 months difference in survival just by allocation where you're being treated. Education, how to use these drugs and how to keep patients around managing side effects, I think is critical, and we should never underestimate the value of what we are doing here, meaning trying to talk about these advances and educate the audience, about what's happening.
I also think the very personal interaction with the patient and looking at their disease status. There's a big difference if you have an individual with a liver extensively involved with tumor, maybe peritoneal disease, and compare that individual with someone who maybe has a few liver metastases or lung metastases. This all has to go in the discussion of can people tolerate a break from a disease control perspective, and that's going to vary considerably based on the disease status. And if you have a patient who gets a wonderful response and they're doing really well, that's an ideal situation to give a person a break, and certainly the patients appreciate it. My patients, will use the summer. I'm going to take a summer vacation, and they get 4 to 6 weeks off. And,
is that because of the heat in Chicago? Or?
We can be pretty hot here. But, I think people come back, they're feeling better and then ready to take the next step.
But let me ask you in follow-up to that, because if you're going to build in a holiday, there are many ways you can do it. You can do it after X cycles, you can do it after X months, or you can do it after maximum response. Do you tend to continue treatment in a responding patient until they're not responding anymore, or do you still allow them earlier breaks?
Well, I think if we look at the majority of the population, most people, the most optimal response is going to occur within the first 2 to 4 months. In fact, that is part of the rationale for example, liver resection and metastatic disease with the neoadjuvant concept of giving abbreviated therapy. It reduces liver toxicity, but also we expect that's going to be the best response period. After that, for the most part, we see stabilization of plateau effects. So I think at that point of time, and when we talk about reducing the risk of oxaliplatin, neurotoxicity, and giving people maybe 6 cycles of therapy and dropping the oxaliplatin, that makes sense, because not only can you reduce neurotoxicity, but you've probably gotten the very best response you're going to see.
Yeah, and I think where we are right now is getting back to the art of medicine, right? And what we've learned from so many of these trials is that we can make those choices. It's safe to do that. We can give breaks, we can choose different therapies, we can treat people on the continuum, and it's all right. Their outcomes are probably going to be good. Tony, we've talked so much about first-line therapy. Let's talk a little bit about second line. We still have a lot of the same players in the second line. We have a little bit of additional player in the second line. Any specific comments about thoughts on second line therapy?
Well, I think really second line therapy depends on first line, obviously. And now with, the thoughts about expanding the RAS analysis, the options remain the same. But the planning should start ahead. The question is certainly now that we have the comfort, from 80405 of understanding that we can maintain pretty much our standard of care right now, at least from the practical standpoint. And so the second line really depends on the outcome of the study, which means our standard of care in the first line, whatever it is, whatever biologic it is, frankly. I mean, all biologics seem to be equal. All backbones seem to be relatively equal. Then we think, at least in the particular RAS wild-type patients, that if your biologic is an EGFR inhibitor in the first line, then naturally it's acceptable to use the other biologic and switch the chemotherapeutic, or vice versa. So we have the options that remain the same. Unfortunately, I must say that if we start refining, which we should with the RAS wild-type population, the RAS mutated populations keeps on expanding, our options actually keep on shrinking for about 10% of the patients and overall 50% of the patients. And this is an area of significant need. So I don't think overall, other than refining the RAS situation and essentially understanding a little bit more about increasing choices in the first line, overall, unfortunately, other than the refinement, we haven't expanded significant choices in the second line, other than what we have today.
So Tony, recent approval, panitumumab, news just before ASCO, first-line therapy. What are your thoughts? Are we going to use it? What do we do with that data?
It certainly has been data lingering around for multiple years, and it actually is listed on the NCCN guidelines. This just confirms that this is a valid addition to FOLFOX versus FOLFOX alone. I'm not sure it's going to change much our practice today, other than just validate that this is an acceptable option.
Excellent. And then Al, so we had 80405 looking at bevacizumab versus cetuximab. We've also looked at the PEAK study, a smaller study albeit, looking at panitumumab-based first-line chemotherapy and bevacizumab-based first-line chemotherapy. I think that Randy and Hecht and Lee Schwartzberg presented that pair of studies both in the first line and second line. Any big differences that we saw there?
When you look at the larger landscape here, I think it becomes very hard now that we have the advantage of some of these other trials to really differentiate in making a choice of what biologic you use. And certainly for me, when it comes to anti-EGFR therapy, the cetuximab, panitumumab, they're active drugs. They can be used across the board in any setting and with our two major platforms. And I think if now we have to put this together. We have focused a bit on some of the individual trials, and they're a little bit different, perhaps. But in the big picture of what we've learned, especially at ASCO today, I think this has got to be your conclusion.
And I actually, just to time, if we talk about panitumumab in PEAK and SPIRIT, and you look at cetuximab, how would this play out? I think they're interchangeable.
Yes.
I look at it as a class effect. We owe panitumumab trials the RAS analysis and actually KRAS analysis. And we have actually clinical data that they are interchangeable and have same efficacy. Actually, panitumumab was approved based on PFS data, so the FDA mandated a head-to-head comparison with cetuximab in the last line setting. So actually, the ASPECT trial enrolled 999 patients in a salvage therapy setting, mainly outside, of course, outside the US. And in KRAS exon 2 wild-type tumors, we saw data at ESMO ECHO last year. It's published in Lancet Oncology. Completely overlapping activity. Side effects, more infusion reactions, surprise, surprise, with cetuximab, more hypomagnesemia with panitumumab, but response rate, PFS, overall survival, you can't even put a laser pointer between it. So there's really, it's absolutely identical. So I think, in guidelines, panitumumab, cetuximab, in combination with FOLFOX in first line, in clinical practice, I think in all
I do think most importantly from ASPECT is also the rash. The rash was very similar in the two arms. And there was a common misperception that panitumumab perhaps induces a higher incidence of rash, and it ended up being pretty similar on that trial.
I think that the one thing we now can turn to for those differentials would be the cost effectiveness and the cost of the drugs and the cost of what we do. We do have to be cognizant of that. And again, within 80405, there's a detailed cost effectiveness pharmacoeconomics assessment, and we have to look at that as well. It's interesting. FOLFOX, of course, during the course of 80405, oxaliplatin was still a patented drug. as opposed to FOLFIRI. So the cost differential was very substantial, and that's not so much the case. But I would think that as we go forward, if panitumumab or cetuximab differentiate themselves in terms of cost, that is something we'd have to think about, because at the end of the day, if they're equal, we should think about toxicities, or we should think about the cost effectiveness.
And Johanna, I think we'd be remiss if we didn't remind our audience that our very lengthy discussion on RAS as applicable to cetuximab is also applicable here. Axel talked about some exon 2 testing, but PEAK certainly had extended testing,
At the
same
ASCO,
same
yep.
exact issue,
Exactly.
all RAS.
So it sounds like interchangeable.
Unless
dealer's choice at
you
the
live
moment.
in Tennessee or the Southeast.
Well, that is true. We all, yeah.